Assalamualaikum.
Let me just make. No, that's fine. It's okay. सॉरी, मेरे आज ऑफिस में ऑलरेडी मीटिंग हो रही है, तो मैं दूसरों के ऑफिस में आके बैठ के लोग पीछे से आते रहेंगे.
If you are having
So today we were supposed to talk about DKA, which is very self-explanatory, and I think from the name you can very easily judge that it's diabetic ketoacidosis. So I normally want to ask from people questions that, have you seen any patient of DKA, Gulizara?
Yes, I have actually during my house job. Plenty of patients, most internal medicine patients were DKA.
Okay, so how do they present?
Sorry?
How do they present?
Most of them altered sense of consciousness, abdominal pain, nausea, increased appetite, polydipsia.
Okay, so normally the DKA is mainly in type 1 diabetic patients who are insulin dependent and they don't have enough insulin in their body. Usually the patients are young. You will see in their 20s, 30s, or even younger, because sometimes the presentation of DKA is the first time they are presenting with diabetes because they're not been previously diagnosed with diabetes. And the first time they present is DKA, and that's a quite life-threatening condition. It's quite severe, and it needs urgent treatment. And if you don't treat it sooner, then patient ends up in ITU or with lots of later complications. So normally they are young patients. They come looking very, very unwell. They look dehydrated. They look sweaty, clammy, pale, dry, and sometimes drowsy. And they look really ill from the end of the bed. So if you're not aware of what's going on, and obviously you will start your assessment with ABCD approach. You give them oxygen, you make sure their airway is patent, you talk to them. Then you go on to B, you listen to their chest, and then you go on to C. Put a big line in because you're looking like a dehydrated person in front of you. Whose numbers may look okay, may not look okay. But you are actually seeing that they are not looking great. So you start IV fluids because that's the most important thing. The first bag of fluid should be like stat 500 normal saline or a liter that you are in the meantime that you are assessing. So that would be your first thought. Checking blood sugar, because if you see patients from ABCD approach, this is what we know that we are talking about DKA. That's why we know that we are dealing with DKA. But if you see a sick patient coming who you don't have any idea, then you will continue your ABCD approach. So when you come on to C, you see a very dehydrated person in front of you, you will start fluid anyway, won't you? So you start the fluid, you take their bloods for full blood count, euthymides, clotting, their blood gases. And then when you look at the blood gas, you might realize then that their blood sugar is really sky high. It normally goes up to 40, which is, I think in your case, is about 280, Alicia.
Did you ask a question? Sorry, I didn't catch that.
No, I was asking Alicia about the exact dosage. Not dosage, sorry.
I think it goes up to 550. जो हमारा AQ check है ना, वो 550 तक उसके ऊपर फिर high show करता है.
अच्छा, हमारा 40 millimoles तक जाता है और 40 millimoles से अगर ऊपर हो जाए तो it goes as high. So it gives you a high alert. तो patient की blood sugar बहुत ज्यादा है. तो जब आप इस किस्म का पेशेंट देखें और वो यंग भी हो, मतलब why would you expect a very young person in this state of condition is usually decayed, diarrhea and vomiting, dehydration. So what do you normally do? Once you check their blood sugar and it's really, really high, the next thing what would you look at is your pH on the blood gas. because there are three things which you need to make your diagnosis of diabetic ketoacidosis. So that's diabetes, which is your high BM. Keto means ketones, so you check their ketones, and then acidosis, then you got with high sugar, they've got acidosis with pH of low, less than 7.1 or 7.2 somewhere. So these three things, if you have got, then you can make a diagnosis of diabetic ketoacidosis. Then you start treating your patient, print out the guidelines, and it's basically the same as ABCD approach. So I'm just going to share my screen that has got the DK protocol. So what normally happens, Gulezara, can you tell me a little bit why this all happened in the diabetic patient? Is she here or is she gone? Okay, so there you go. I think she's lost. So diabetes, you don't have enough insulin. Your body is not making. So you're diabetic. So your body has got no insulin or insulin resistance, but your sugars go up high. Okay, so once the sugar go up high, then the whole mechanism of all sodium, potassium channels, your lipolysis and gluconeogenesis, all these processes begin, which is more of a physiology, which I'm not going to go into, because our main aim is to a little bit of understanding of how things work and what we need to monitor and what we need to treat. So first of all, you have figured out that blood sugar is high, so you need to bring blood sugar low. The second thing is acidosis. How can you improve acidosis, and how are you going to monitor, because ketones come from the body when it's going into this cycle of vicious circle. Then you have to get your ketones under monitor. So start the fluids. I think three things which are important is insulin, fluids, and strict monitoring. So like I said in the beginning, if you have got very serious patient, if you see the pH of less than 7.1, which is very, very acidotic, and they've got ketones of more than 6, if they are drowsy, their GCS is low, which are normal ABCD approach anyway. If you find abnormalities there, you are going to call intensive care. I think sometimes it's a bit earlier to call ITU, because if you start the treatment, patient really improves very quickly. Within an hour, you will see a totally different person. If you start your management, so even if you call in the beginning, the ITU inform them, they will say that, okay, start your treatment and we will come down. By the time they come down, patient looks slightly different, they improve, they respond very quickly. But if the first initial treatment, if you don't have much response, only then you have to worry about ITU and intensive care and extremes of age, like in children, for example. But you don't see children anyway. So the worrying things, blood pressure very low. You start your normal saline, and then you can always give a bolus if patient is looking very, very dehydrated, so 10 to 20 milligrams per kilograms, milligrams per kilos, whatever. So you give fluids. And then the second, I think, obviously we all can't remember all this regime. It's all written here. So we just go along with these protocols, which we need to follow. So when the patient is having diarrhea and vomiting, they lose their potassium, they become hypokalemic. And if you give them insulin, the insulin is going to take your potassium out as well. So we don't start insulin straight away before we give the fluids, because your sodium potassium channels are disrupted and your extra intracellular potassium is different in a normal, whatever is normal should be. So if you replace the fluid first, then you will have less potassium in your extracellular fluid, and only then start insulin. So normally it's not recommended to start in the first hour the insulin management, because once you give insulin, it's going to remove the potassium from your blood and patient can go hypokalemic even further. Okay. So you check the potassium, they might be okay. If it's less than, I don't know, your units. For me, it's 3.5 or something. If it's less than that,
They're the same.
yeah, if potassium is less than that, then I would hold off with insulin. Then I wouldn't give insulin. But I will replace the fluid first, because fluid is the most important. As you can see on the left-hand side, the intravenous fluid, it says sodium chloride in the first hour, second hour, third hour, and fourth hour. So the first hour, they did not add any potassium because we want the normal chemistry to come back a little bit to adjust the potassium to go intracellular or extracellular. So what the normal state comes, and then you recheck. And if the potassium is high, then you start, I mean, not high or maybe not enough, low enough to start the insulin. So you start the insulin then. And if the potassium is going, because you really need the insulin to treat the hyperglycemia. And at the same time, you don't want your potassium to go low. So what you do is to compensate your effect of giving the insulin by giving a bit of potassium. Okay? Because you are now treating hyperglycemia, which is very, very important to be, and you are starting the Ectrapid 50 units in 50 mils of normal saline, and you start it, and you know that it is going to reduce your potassium. So once you don't want the potassium to go down, so you start slowly replacing that potassium, and that is keeping the balance of the both. And that's why it's very important that when you are treating a DKA patient, they have to be on a cardiac monitor, because you are playing with their potassium. Okay, so it can go high, it can go very low. So hypokalemia can cause ECG changes, arrhythmias, asystole, and hyperkalemia can cause VT and all that sort of arrhythmia. So it's very important that whenever you give potassium, you always monitor the patient. Then we come up to insulin that we have looked. It's a generic rate of infusion of 0.1 unit per kg per body weight. So you really ideally have to have a body weight of the patient, and then you calculate that how much insulin do they need, and this is 0.1 unit per kilogram per hour. So it's you have to calculate. It's easy once you understand and you know the weight, rough weight of the patient. If they are less than 50 kilos, or if they are more than 140 kilos, then I think there is a specific limit that you should not be go below that. And I think if it's less than 50 kilos, then you should be following the pediatric protocol, which might be slightly different in calculating the deficit of fluid and the insulin itself. Also, I think when you are monitoring the blood gases, sorry, did you say something? So at the same time, you are starting monitoring your patient. You need to see the effect of your treatment. So the first hour of treatment is very, very crucial, very important that you keep doing your ABC assessments, and you will see within an hour, patient, you need to start looking at the symptoms, what you need to treat. If the patient is persistently vomiting, maybe antiemetics would help. You are replacing the fluid anyway. If they have got pain, they normally can have abdominal pain. You can give them pain relief. So all the symptomatic treatment will go alongside. Blood gases, you do bedside urinary ketones, I believe, and that can be repeated every 1 or 2 hourly to see how much you are responding and how much pH is coming down and how much blood sugar is going down. So you don't want to suppress blood glucose very quickly, and that's why we don't give subcutaneous insulin or short-acting insulin, because that effect is going to be for short time. But if the book says if the blood sugars are really, really high, I mean, if it's beyond calculation, you can give a small bolus of subcutaneous insulin and then start the insulin infusion. Okay, so that would do the initial process of bringing the blood sugar down, and then you continue it with by giving the infusion to slowly reduce. What do you think, Gulisara, is the most worrying complication of DKA?
It could be coma or kidney failure.
So I think it's cerebral edema, which you are really concerned about. And also people think that, it's because of overhydration. It's basically because of dehydration, because of your bicarbs, because of your carbon dioxide, because you're breathing in a different way to compensate your acidosis. So there's a lot of physiology involved around the DKA procedure, because you have seen they have got specific breathing pattern in DKA patients because they are too acidotic and they got metabolic acidosis on their gas, on their blood gas, but they're trying to compensate by putting the respiratory element in it, so they get alkalotic as well. So it's different in different patients with I think the metabolic acidosis with high anion gap. So in DKA, do you know how to calculate anion gap? No? Gulizara?
Total sodium minus total bicarb.
The sodium plus potassium. So you got your positive ions on one side and you minus them with bicarb and chloride.
And chloride, yes.
Yeah. So it's usually above 11, 12, 13 is the normal range. But if it goes beyond, I mean, in DKA, you might see the anion gap is going up to 30 or, up 25, 30 normal max. So you have basically have to reassess your patient. Okay, you have started the management. The important things in the management is you give them fluids quickly. You don't start the insulin straight away. You don't give subcutaneous insulin if the blood sugars are still, on the monitor. You have to monitor the patient's response by giving fluids and checking their ketones and blood gases. Okay, so normally within an hour, they start to get better. But the fear is that you can have cerebral edema. So that's why their treatment, because of dehydration, the cerebral edema, it needs to be picked up soon. If they're getting under, lower conscious level, they are not responding and the GCS is getting low. So, and it's in the DKA is very, very severe. Like the pH is 6.9 and base excess is going beyond, like very severely bad numbers. Obviously, then patient needs to be intubated because they will not be showing any signs of improvement, bed tilt up, because that is going to increase your intracranial pressure. So you don't want the cerebral damage. So if you figured out, then you try and reduce the damage by doing different techniques, catheterize the patient, tilt 45 degrees and intubate, all these sort of things which can reduce the intracerebral pressure. I think that's basically is about DKA, and if you see that patient in an hour's time, that might look completely different. I just want to make sure that I have spoken about all these things. So you check their bloods, you make sure they're not in kidney failure. So what normally triggers DKA?
Missing doses of insulin. Missing the insulin doses, that's one of the reasons.
Yeah, so normally if patient is, maybe if they are not diagnosed with DKA and they're not on insulin already, then not having enough insulin in their body, and on top of that, if they have got some sort of infection, if they have got some sort of stress or any response of the body that is causing under stress, then this DKA occurs. So in middle-aged people, stroke, MIs, any body trauma, dehydration, or any sort of infection anywhere, it triggers the DKA. And obviously, if they're not compliant with the medication, if they're not taking their insulin regularly, if they're known to have insulin-dependent diabetes. So these will be mainly the young people, and it could be the first presentation. Okay, so 3 things: fluids, insulin, and continuous monitoring. So I think you have to have be patient with these patients, because you won't see a dramatic change in first 10-15 minutes. You have to be persistent with your treatment, and once you detect that by checking their blood sugar, their acidosis and their ketones, so your diagnostic criteria is filled. The second important thing is that you have to make sure that they're not too unwell to ITU to be involved at this stage, which is clearly written. If I go a little bit back, just in the gray box here, severe DKA, only in that case, you will have less suspicion, you will have more suspicion of them not getting better quickly. Okay? And then the third thing is you start your management according to the protocol and continue the management. So any questions with this? I think the rest is all about the drug charts and how you actually prescribe things. We just normally make sure that we do the chest X-ray, we do the ECG, all the required baseline investigations that are needed for the patient. If it's the first time of presentation that the DKA in a young person, then how are you going to tell the patient, to the family? These are sort of things which are important, and when they get better, obviously they will stay in hospital, then make sure that they will have a follow-up with endocrinologist, whoever is going to diagnose, and put them in the right medication. And obviously lots of questions from the patient if they get better when they ask, which I'm sure they will not ask in the emergency department, but if like a newly diagnosed diabetic. So it's a diabetic emergency. Patient arrive in a day or two, they become so unwell that they can't even reach to the hospital. They just think it's a normal diarrhea and vomiting, and they try and drink lots of water at the same time. They're passing lots of water out. They get dehydrated, they become sick, and then they come to you and they feel better.
इसमें 2-3 पॉइंट्स याद रखने वाले हैं. एक तो ये है कि whenever you get them diagnosed, always put 2 granulas in, one on each side, and there should be at least 20 gauge. और एक से आपने इंसुलिन मैनेज करनी है, और उसमें आप जो है ना उसको आप चेंज ना करें. और जो दूसरा है वहाँ पे इलेक्ट्रोलाइट्स और फ्लूइड्स होंगे, और एंटीबायोटिक्स उस पर चलानी तो उसमें चलेगी. ठीक है, तो एटलीस्ट 220 gauge granulas are recommended. नंबर 1. नंबर 2, उसमें ये होता है कि एक्यूट किडनी इंजरी में कई लोग परेशान हो जाते हैं कि जी क्रेटिनिन ज़्यादा है, हम इतना फ्लूइड दे रहे हैं. ये इसकी फिजियोलॉजी में एक्यूट किडनी इंजरी की फिजियोलॉजी प्री रेनल होती है मोस्ट लाइकली, और इसमें फ्लूइड देने से वो बेहतर होगी, और यू विल सी द डिफरेंस के यूरिन बनाना शुरू कर देगा वो. और इल्ला ये कि पेशेंट को एटीएन हो जाए, लेकिन वो बहुत कम रेयर कंडीशन. तो इसलिए आपने AKI के अंदर एलिवेटेड क्रिएटिनिन यूएन के अंदर आपने परेशान नहीं होना. फ्लूइड आपने उसको खुल के देने हैं, एक्सेप्ट पेशेंट इफ पेशेंट इज ऑलरेडी इन फ्लूइड ओवरलोड स्टेट, या उसको हार्ट फेलियर से डीके प्रेसिपिटेट हुआ है या किसी और वजह से हुआ. तो if the patient consider patients hypovolemic unless you have substantial evidence of high fluid overload. ठीक है. नंबर 3 में ये बात उनकी सही है बिल्कुल कि जी आपने शुरू में फर्स्ट आवर में आप पोटाशियम रिप्लेस ना करें, और उसके अलावा फिर आप पोटाशियम रिप्लेसमेंट अकॉर्डिंग टू द प्रोटोकॉल करें. नंबर 4, आपने इंसुलिन ड्रिप उस वक्त तक बंद नहीं करनी जब तक के कीटोन्स ऑलमोस्ट नील ना हो जाए या 1+ ना रह जाए. क्या हम यहाँ पे एक्चुअल वो तो नहीं कर सकते, क्योंकि इंसुलिन जो है वो ड्रिप में उस वक्त तक चलाएंगे जब तक कीटोजेनेसिस आपकी जो है वो खत्म ना हो जाए. एंड यू विल probably actually see that ketone urea actually increases initially, but the anion gap closes. anion gap close होगा और कीटोन्स थोड़े से बढ़ जाएंगे यूरिन में, और उसके बाद कीटोन्स कम होना शुरू होते हैं। तो आपने एन गैप को अपने उसमें रखना है। और हमारा पुराना प्रोटोकॉल जो मुझे हाउस जॉब से याद है वो ये है कि इफ द ब्लड शुगर स्टार्ट्स गोइंग डाउन बिलो 150, तो आप उसको सेलिन को, अगर आपके कीटोन्स खत्म नहीं हुए यूरिन में से, तो आप सेलिन को D5 के साथ कवर कर देते हैं, बट यू कंटिन्यू विद द इंसुलिन ड्रिप एंड द D5. You can do D5 half normal, you can do D5 water with potassium, or you can even do you know D5 water with potassium भी आप कर सकते हैं. And make sure that the ketones are less than 2+, 1+ हो या nil हो जाए, तब आप उसको subcutaneous insulin. And whenever you switch to subcutaneous insulin, always do it an hour before you stop the insulin drip itself. तो उसमें gap ना आए. जी.
सॉरी मेरे उधर अनाउंसमेंट।
अच्छा अच्छा, तो ये चीजें हैं। सीवियर डीके का जो है ना क्राइटेरिया आप नोट कर लें, इनमें से कोई भी चीज होगी तो द पेशेंट शुड गो टू द आईसीयू, और मोस्ट लाइकली हमारे 90-95% पेशेंट आईसीयू में ही एंड अप होते हैं, क्योंकि दे आर एक्चुअली कम इन वेरी लेट. Like we had a patient about 2 weeks ago, young patient who stopped his insulin with a pH of 6.9 and a bicarb of 5.
Oh my God.
So,
Then?
or he was actually told by a physician to stop the insulin because he was told he was not diabetic anymore. That's the irony of the situation. But
Was he diagnosed in the department?
he was diagnosed previously and he was actually on insulin. But then was told to, he was switched over to oral hypoglycemics and his insulin was stopped. In 2 weeks, he ended up with critical illness, almost died. So, I mean, you remember Bilazara, I think you remember that patient. He was a police constable. Yeah. So,
Okay, so
this
that's,
is
good points, Sir. Thank you very much for adding these points. I think, like I said before, because we discussed the topic and start with our topic, that's why we know what's the diagnosis. In coming days, we will do such scenarios when I will give you the scenario and you start doing your ABCD approach, and then you will find what's the actual cause was. I think we tried on the WhatsApp group, which is very good, and it's good to treat patient without even knowing their diagnosis. So just to keep ABCD approach, and if you, in this patient, if you continue to do so, by the time you reach to blood gases, blood sugars, you will pick up the abnormality, and you will pick up that they are acidotic, they are high blood sugars, and then you will ask for ketones to make sure they're not diabetic ketoacidosis. Okay, so keep your approach the same. Any sick patient, any dehydrated, ill-looking patient, make a habit of putting 2 cannulas in anyway, no matter what. Because if one goes, and if they go more peripherally shut down, then it becomes very, very hard. And it would be a shame to lose a patient just because we could not cannulate them. So when they arrive, make sure you put big bore cannula in both arms. If they are unwell, there is no harm taking one out if you don't need one, or if you're not using one. There is no harm putting 2 at the time when you really need to, rather than struggling and missing the doses of what you need to give them. So keep these little tips in hand. Any sick patients, 2 cannulas, start the fluids, and anticipate that they can go further down to try and avoid getting them even much more sicker. So that should be the aim. Okay, so I think we'll stop here. I actually have to go back to work, and inshallah next time we will decide what will we do. Okay.
Right. Thank you so much.
Thank you very much. Have a nice day, and
thank you very much.
soon. Thank you.
Assalamu alaikum.
Assalamu alaikum.